Ruby has mentioned, I'm a consultant at the Manchester Royal Infirmary, which is here. For those of you who aren't familiar with Manchester, it's a big city in the centre of the UK. It counts as the north of England. So we are northerners up here. And my main role here is as the clinical lead of the Cochlear implant programme. And I'm speaking today about temporal bone fractures, which is something that you guys do need to know about. And I was thinking to myself, what do you need to know, or what do you want to know about temporal bone fractures? Because they're one of those things that not a lot of people have a special interest in. They're one of the things that you get called to see, often in the middle of the night, often when you're on call alone. And so I figured you might like to know a few basics about the clinical approach to these trauma conditions, and perhaps things that might pop up in your exams. And so if you're looking for something more complex than this, you might be a little bit disappointed, because I'm going to keep this quite simple, really clinical, and hopefully just give you a few really key takeaway messages that will be useful in your clinical practice and also in the exams that you guys have coming up. So very quickly, to talk about the epidemiology of temporal bone fractures, they usually arise from a blunt head injury. These aren't the stabbings that we see. These are blunt trauma to the head, usually to the side of the head, although not always. They're often associated with other intracranial injuries. So if you are called about a temporal bone fracture, just keep in mind that you might not be the only person that's looking after this patient. If they have a serious brain injury in association with their temporal bone fracture, they will need to have neurosurgical input as well. Temporal bone fractures are about 20% of all skull fractures, so they're fairly common. And in the biggest case series, I found they are present in about 3% of all trauma patients from a big series. So these are quite common conditions. Perhaps most importantly for you guys, your examiners will like to ask about this topic. And the reason for this is that the temporal bone has all the things in it that we love to talk about and we love to quiz you on. So complications of temporal bone fractures include hearing loss, which we can talk about all day, every day, balance problems, the same, facial nerve injury, which is a massive, massive topic, and CS left leak. And so these four things are things you should be keeping in mind as soon as you hear about a patient with a temporal bone fracture. And as soon as one pops up in your exam, you should be thinking about these four potential complications. In terms of hearing loss from temporal bone fractures, this can be conductive if the ossicles are dislocated, or it can be sensorineural if there's a crack through the otic capsule, and we'll talk a bit more about that later. In terms of balance problems, these can be permanent. If somebody cracks through their otic capsule, they'll have a permanent loss of balance which will never return. But they can also get temporary balance problems. Patients with head injuries are quite likely to get BPPV post-operatively, and this is something that you'll also need to keep in mind when you see these patients. Facial nerve injury, it's really important that you have to think about whether it's complete or partial and whether it's immediate or delayed, and we'll talk about that shortly as well. CSF leak is something that might fill you with horror. It is a condition where you probably will be involving your neurosurgical colleagues, and in general, if there is some leakage from the brain or in the ear, it will be a CSF leak in the shorter term, and in the longer term you can sometimes come across a perilymph fistula, but this is fairly uncommon. So in terms of clinical presentation of temporal bone fractures, you'll all have heard about battle sign, which is the bruising behind the ear. Actually, this isn't always present acutely. Lots of patients with temporal bone fractures do not have a classic battle sign. So by all means look for it, but don't use it as a guide as to whether someone's got a temporal bone fracture or not. In general, if someone's had a serious head injury and they have a facial palsy or suffering from really bad dizziness, or you can see some nystagmus, just think about the temporal bone. Think about whether they've fractured through their facial canal or their otic capsule. And of course, if you see someone bleeding from their ear or with CSF or blood coming from their ear or their nose, you're immediately going to be thinking about a temporal bone fracture and how you need to manage this. So classification of things is something that you guys love to talk about in your exams. And there are two different ways of classifying temporal bone fractures. The classical one is to talk about the fracture relative to the axis of the temporal bone, i.e. longitudinal, which comes along the length of the temporal bone, and transverse, which goes across it. And the textbooks will tell you that the longitudinal ones are more likely to affect the facial nerve and the otic capsule. But actually, in reality, the fractures of temporal bones don't tend to go in a straight line like this. They tend to be curved or mixed or go in all sorts of different directions. And therefore the other classification, which is whether or not the otic capsule is involved, is much, much more useful, because actually a lot of the temporal bone is just honeycomb bone, as you guys will know, because you've hopefully drilled mastoids and found out what's in there. But there's some really important stuff in there as well. And it's the important stuff that we worry about being injured in trauma. So in your exam, when you're asked about the classification of temporal bone fractures, a good answer will be classically, they are classified according to their direction, according to the axis of the temporal bone. But actually a more useful classification is whether or not the otic capsule is involved in the fracture. So just some images to show you. This is a real patient of mine that I saw not too long ago, a young gentleman who fainted and fell onto a hard surface. And this is a longitudinal fracture. And this is a picture, it's just a single image, but it shows you everything you need to see. And there are three things that I really like my registrars to point out. The first is that there's a crack in the temporal bone, in the cortex of the bone. The second is that there's some opacification of the mastoid air cells, and this is blood in the mastoid air cells. And the third is that there's a crack heading into the otic capsule, and there's some air in the cochlea. This is the cochlea. There's the basal turn of the cochlea. This is the middle and apical turn of the cochlea. And the cochlea, as you know, should be filled with fluid. And this cochlea has some soft tissue in it and some air. There should never be air in the inner ear. If there's air inside the otic capsule, i.e. the cochlea or the labyrinth, there's probably a fracture. And this will give the patient permanent loss of hearing and balance. So here we have a longitudinal fracture, a crack in the cortex of the bone, a opacification of the mastoid air cells, a breach of the otic capsule, and some air within the cochlea. Here's a transverse fracture. These are less exciting because they tend not to involve the otic capsule. These do give you impressive retroauricular bruising. So a patient with a transverse temporal bone fracture will have really impressive battle sign, but probably won't have much else to see when you go and examine them. But you can see that nice and clearly on the CT scan. So why is otic capsule involvement more important than direction of the fracture? And of course, this is because clinical signs trump radiology. We love to get cross-sectional imaging, but we mustn't rely on it. And so I'm going to talk through some of the points in this theme with a case, a very real case that we saw at Christmas time this year. So this is a 25-year-old man, and I know that at least one of you online this evening has come across this patient as well, and will have heard of him before. He attended the emergency department at about 10 p.m. one evening. He was very unsteady on his feet, but he had been drinking. He'd been allegedly struck on the back of the head, had briefly lost consciousness, had vomited twice. CT scan done in the emergency department was reported as normal, but because he lived alone and he'd lost consciousness and he'd vomited, he was kept in hospital overnight on a trauma ward. Now, he woke up the next morning very dizzy, and the trauma team called ENT, who, for whatever reason, didn't go and see him. And the following day, they called the ENT registrar, who, for whatever reason, didn't go and see him. And the following day, they called me and said, "Oh, just wonder, sorry to bother you, but I just wonder if we could ask you about this guy. He's very dizzy. He's very dizzy after a head injury. But your registrar won't come and see him because his CT is normal. He doesn't have a temporal bone fracture." And I was in theatre at the time, so I pulled up his scan before I went to see him and had a look for myself. And you can have a look at his scan as well. And immediately when I pulled up his scan, I look at scans all the time, by the way, so I'm very, very used to picking up subtleties. And when you look at this, you might think it looks normal. There might be some things that jump out at you. If you're a rhinologist, the sinuses might jump out at you, or these big turbinates. And actually, of course, we're looking at his temporal bones. And when you first look at the temporal bones, there's no blood, there's no opacification, there's no obvious crack going through the cortex, but look, boom, air in the basal turn of the cochlea. So if you look on the normal side that's not had trauma, there is fluid in the cochlea. And if you look on the side that has had the trauma, air in the cochlea. And of course, once you've spotted the air in the cochlea, you can see this fracture going through the petrous face. So this is a different type of temporal bone fracture. It didn't come longitudinally. It is transverse, but it's right through the otic capsule. So the radiologist and the A&E doctors reported it as normal. But of course, this is a very, very serious injury. There's air in the cochlea. If we scroll through, we can see some air in the vestibule, air in the lateral semicircular canal, and this crack heading right towards his jugular foramen. So he's lucky to get away with complete loss of hearing and balance. So of course I went to see him, having looked at his scan and knowing that he would have complete loss of hearing and balance. And one of the first things I did was do a Hamagi head thrust test. I'm sure you guys know what this is. This is a very easy bedside way of seeing someone has an acute vestibular loss. And it's based on the vestibular ocular reflex, in that you get the patient to look at you, you ask them to keep their eyes on you, you turn their head. And if they've got normal vestibular function, they keep looking at you because their VOR keeps their eyes fixed. And if they've got an acute vestibular loss, when you move the head quickly, their eyes will move with their head and they'll flick them back. And it's this flick back to center that's the saccade. That's the abnormal part. This was his pure tone audiogram. And it shows exactly what I expected it to show, which is normal hearing in the left side. Really good hearing, actually, right up at 0 decibels. And on the right side, unrecordable air conduction and unrecordable bone conduction. This is a right dead ear and left normal hearing, and it completely fits in with what we saw on his CT scan. Of course, I have some really great audiology colleagues that I work with, so I asked one of my colleagues to see him for some vestibular function tests to just clarify what was going on. And he saw my colleague a couple of weeks after his injury, and these are really interesting results. What they show is that he has a profound right-sided vestibular loss, but that he was already compensating for it. So here my colleague has done some vibration-induced nystagmus, and this confirms that with fixation, he didn't show any abnormalities. So with fixation, he compensated for vestibular loss by using his vision. But when fixation with his eyes was denied, he showed some signs of vestibular loss on the right-hand side. And the video head impulse test, that's the advanced video version of the Halmagyi head thrust test, where repeated head movements can be picked up by video goggles. I'll show a picture of it in a minute. And what this showed was that on the left, this is all normal, and on the right, he was having big clustered saccades, covert and overt. And this all confirms his right complete vestibular loss. And these are tests that you should do if someone's had a significant temporal bone fracture and you want to see whether they've had their balance function affected by their injury. If you haven't seen them before, this is a patient wearing the goggles that they would wear for a VHIT, a video head impulse test, and the audiologist moves the head repeatedly and picks up these lovely curves. So the green curve is the movement of the head, which follows the movement that the audiologist is doing, and the red curves are the saccades. So these are the catch-ups. So if the patient had normal vestibular function, you'd expect their eyes to follow the normal line. But if they've got a vestibular loss, these are catch-up saccades. This is the eye not moving when it should have done, and then moving again to catch up. This is a right-sided vestibular loss. And if you haven't seen these tests being done, I would go and speak to your local friendly audiologists and go and watch them being done, because they're actually a lot of fun. They seem really complicated when you're learning about them, but when you go and watch them being done, they're really, really interesting. So how do you manage balance loss? Well, after a temporal bone fracture, if a patient has had a fracture through the aortic capsule, this balance loss will be permanent and complete. And the only way to rehabilitate their balance is through rehabilitation physiotherapy. And this is a process by which a trained physio will teach patients to balance using their remaining good inner ear and their vision and their proprioception of their limbs. And most adults can rehabilitate to the stage where they feel normal on a day-to-day basis. But it's a bit more work for them to balance than it is those of us that have two working inner ears. So if they're tired, if they're dehydrated, if they're run down, or if they try to walk around in the dark when they can't visually fixate, they will still suffer from balance problems. But rehab is brilliant. It gets them about as good as they can be. I mentioned earlier that actually after temporal bone injury or any serious head injury, BPPV is really common. And so when you see these patients and they give you a classic history for BPPV, please do an Eppley maneuver, because this can really resolve some horrible BPPV symptoms that these guys have. So remember about the permanent balance loss, but also remember about the BPPV that's really, really common after serious head injuries. Okay, so how are we going to manage his complete permanent hearing loss? Here's our patient's audiogram with normal hearing on the left and hearing that's completely gone on the right. And what we know about hearing is that once it's completely gone, we can't actually really bring it back. In the UK, you can have a cochlear implant if you're profoundly deaf bilaterally, but actually if you've got one good ear and one dead ear in the UK, you can't have a cochlear implant on the NHS. You can go and pay for one privately, but the NHS will not fund one for unilateral hearing loss. Actually, in some countries around the world, for example, Germany, Australia, and some other European countries, the insurance companies will offer you a cochlear implant for your single-sided hearing loss. And if you're going to give a cochlear implant to someone who's had a temporal bone fracture and disrupted their aortic capsule, you probably have to move quite quickly, because a disrupted aortic capsule is going to be at risk of obliteration. So cochlear implants are not a very affordable option in the UK, but actually just think about them if your patient has bilateral hearing loss, or if you're in a country where this is feasible. There was a vogue about 10-15 years ago to give bone-anchored hearing aids to people with unilateral hearing loss. And of course, a bone-anchored hearing aid doesn't give you back binaural hearing. It removes a head shadow by picking up sound from the deaf side and delivering it through the skull to the good cochlear. And this is exactly what a cross aid does. And cross aids don't involve any surgery, and they can be given to the patient straight away. So if your patient has a temporal bone fracture and they've completely lost their hearing, please don't forget about rehabilitating their hearing. You should at the very least offer them an audiology review, and in the most likely scenario, they'll be offered a cross aid which delivers sound by Bluetooth from one ear to the other ear, and there are other options available as well. Of course, some patients after a temporal bone fracture have conductive loss. Actually, this patient's got a conductive loss on the other side, and there are various options for this as well. You shouldn't just avoid dealing with a conductive hearing loss because they've had a traumatic injury. You do need to think about rehabilitating their loss. If someone's still got some thresholds with their conductive loss, you can give them a traditional air conduction aid, but bone conduction aids are absolutely brilliant for conductive losses. However, the other option for conductive hearing losses, if someone has disrupted their ossicles during a temporal bone fracture, is that you can reconstruct their ossicular chain. Reconstructing the ossicular chain has actually become less popular over time because we know that there are conditions under which ossicular reconstructions work, and generally the patients who've lost their ossicular chain are those with chronic ear disease, and so they do not have a conducive environment in their middle ear for reconstructing their ossicular chain. But a patient with a healthy temporal bone, an aerated temporal bone that's had them dislocated, actually could do brilliantly if you reconstruct their ossicular chain. So keep this in mind if you like operating on middle ears, but otherwise just try and rehabilitate their conductive hearing loss with a bone conduction hearing aid or even an air conduction aid. CSF leak is something we talked about earlier. This is a thing that will strike fear in your heart. And of course, we all learned at medical school about the halo sign, whereby if a drop of blood goes onto a sheet or a piece of tissue or a piece of paper and you see a clear halo around it, this is CSF, and we need to send some off to the lab. Different labs do different tests for CSF, so you absolutely need to collect some of this fluid, whether it's in the acute phase when they've still got a nosebleed or leakage from their ear, or when they come back to see you and they say, you know, doctor, I feel better, the headache's gone, the dizziness is gone, but I'm still getting this watery fluid from my nose. You absolutely need to collect some in a tube. But you also need to let your lab know that it's coming. So different labs will do slightly different protocols and tests to check for whether this is CSF. So I would give your lab a call, ask them exactly what they want you to send them, and send it to them labeled correctly. I can't stress this enough. There have been a lot of CSF samples sent off that have come back inconclusive because they haven't had the correct tests done. If someone is leaking CSF, you need to put them on broad spectrum antibiotics. It's wise to seek a skull-based MDT opinion, actually, because if someone has had a temporal bone fracture so serious that it's breached the dura and they're leaking CSF, you probably do want an expert to look at this. But actually, most CSF leaks following trauma do resolve spontaneously. And it's just a matter of giving your patient antibiotics and keeping a close eye on them, letting your patient know what the symptoms are that they should be looking out for, and just observing them. And if it doesn't resolve spontaneously, at that stage, you will need to speak to your friendly skull-based MDT again and ask them to consider doing a repair or some further investigations to find out where the leak's coming from. Oh, I'll just go back to that. Earlier, I mentioned perilymphatic fistula. This is really rare. It's a longer complication of temporal bone fracture. If someone's breached their aortic capsule and there's a persistent leak of fluid from it, often they'll get sort of pressure-induced dizziness or just some strange symptoms that aren't quite right. And these are patients you would refer on to a specialist otologist who can do a repair of the perilymphatic fistula. If you get to the stage of talking about that in your FRCS exam, you'll be doing really well. So facial nerve injury is something that they do love to talk about in the FRCS exam, and you do most definitely need to know about. In the acute phase, when you've got a patient who's just fractured their temporal bone, there are two things you want to know about the facial nerve injury. First, is it immediate or delayed? If it was immediate, alarm bells are ringing. Have they transected their nerve? Have they crushed it so badly that it's never going to recover? If it's delayed, it's more likely due to some swelling of the nerve within its canal, and you wouldn't worry so much. So worry more if there's an immediate facial nerve palsy. Also, is it complete or partial? If it's immediate and complete, you're probably going to be picking up the phone and speaking to your friendly neuro-otologist to explore this facial nerve. If it's immediate and complete, they've transected the nerve or damaged it so badly that it needs to be explored. If it's delayed and complete, there's probably still some time for it to recover. You can speak to your neurosurgical colleagues about whether they think that giving steroids is a good idea. Actually, in acute head injuries, neurosurgeons do not like you to give steroids, so always check with them before you give a patient steroids on the basis that they've got a facial nerve palsy. If it's partial, you're not going to go in and explore it. You're going to probably just wait for it to recover and keep an eye on that patient. But the really important thing, clinically and for your exams, is never to forget about the patient's eye care. If the patient can't fully close their eye, please don't just think about the facial palsy. Please give them some eye care as well, and you keep your examiners and people like me very happy. So what other investigations might you like to do if your patient has got a facial nerve palsy after a temporal bone fracture? So we've looked at some CT scans already, and actually, as you guys know, when you've got a nice high resolution CT and a friendly otologist or radiologist to look at it with, you can often see the facial nerve really, really beautifully. You can trace the whole course of the facial nerve, and so you can see whether it's been disrupted. If there's a chip of bone sticking right into the facial nerve, you'll see it. Oh, perhaps this does need to be explored. Perhaps I need to pick up the phone and speak to my local skull-based surgeon. And they're the patients who would probably end up being explored and having their facial nerve decompressed or even repaired if it's been transected. So you're doing a high resolution CT scan to look at the whole course of the facial nerve to see if it's been disrupted in any way. Of course, most patients don't have a complete or an immediate facial palsy. It's delayed, it's partial, it's complicated. And as you guys know, if it doesn't recover spontaneously, you'll think about doing some electrodiagnostic testing to see whether there is integrity of the nerve or not. And you need to think about the old classification of nerve injuries. Mr. Simon Freeman gave a lovely talk about this at the Northwest Teaching Day the other week. And he went into a lot of detail about this, which was really, really useful. And I think that's recorded somewhere. So if you want to know more about this, I'll try and track down Simon's lecture, because it was really good. Mine's more of an abridged version because we're putting more stuff into it. But electrodiagnostic testing, some people say to wait 10 days. Actually, the textbooks say you need to wait 21 days for Wallerian degeneration to occur. And as you guys remember from studying this at medical school, there are different grades of nerve injury. And actually, if you've got an axonotmesis where the axons are divided but the sheath is still intact, you'll get a falsely positive electrodiagnostic test because the nerve has not yet degenerated, not yet shrunk back. It still appears to be intact, even though it's been injured. So yeah, the grades of nerve injury are really useful to think about, not just in terms of investigating the injury following the fracture, but also thinking about recovery as well. If a nerve has been seriously injured, even bruised or swollen badly or partly divided, it'll never quite repair the same. So for example, when skull-based surgeons do an end-to-end facial nerve repair of a transected nerve, it'll never get back to a grade 1 House-Brackman score. About the best you could expect is a grade 3. And that's because when you put the ends of a nerve together as a surgeon, you can put the most beautiful stitches in the world and put some glue around the edge to ensure the best result. But it's the patient's healing that makes the nerve work again. And the ends of those nerves will never heal up exactly as they were before. They heal up a little bit erratically. And this is why you never get a grade 1 from a facial nerve repair. Facial nerve grade 3, where they can get some eye closure and some facial tone and movement, is considered a great success. And it's absolutely normal to get some fasciculation when the nerve endings join up a little bit erratically. If the patient's facial palsy persists and doesn't get better with steroids, with conservative management, it's really worth referring them to a facial function MDT, and most big centres will have a facial function MDT, and they'll have an ENT surgeon, a plastic surgeon, probably an eye surgeon, maybe have a neurophysiologist, and it's a really nice MDT setting where they'll discuss the patient and agree the best management for their facial palsy, which hasn't recovered conservatively. If it's partial, they're likely to offer facial physio. This involves, on the most basic level, just doing exercises, as you would imagine, just facial exercises, but they can also offer sort of electrostimulation machines that can just sort of, what's the word? Oh gosh, what's the word? Like passively exercise the muscles that haven't been exercised for a while to try and get them moving again. They can offer surgical options, either for facial reanimation, which you guys will be familiar with, or just to protect the eye through surgical options. And they also use Botox quite a lot, and this is for two reasons. One is if the nerve has joined up a bit erratically and the patients are getting troublesome fasciculation, they can give Botox to the twitching parts to settle them down. And the other reason is if there's facial asymmetry, they can actually give Botox to the good side to make it match the side with the mild facial palsy, just to give patients a bit of symmetry. And just little things that the MDT can do like this really change people's quality of life, and I guess help them come to terms with the fact that their facial nerve is never going to work perfectly again. They get things as good as they can possibly be. So I think I was given 40 minutes and we're coming in a bit under time because I've been gabbling away at you. The take-home messages from me are about clinical care of these patients. I would say if you're called to see a patient with a temporal bone fracture, go and examine them really carefully yourself. Go down to the emergency department, go and see the patient. Have they got nystagmus? Have they got bruising? Have they got any leakage of blood or CSF from their ear or nose? What do they think about their hearing? What do they think about their balance? What does the facial nerve look like? Just go and have a look at them with your own eyes, with all these things in mind. Have a look at the CT scans yourself. Don't trust the on-call radiologist, who may well be a new registrar that doesn't specialise in the head and neck. Show the scans to your senior, and just always be thinking whether or not there are any symptoms or signs of otic capsule fracture, because regardless of the direction of the fracture, it's really, really important to consider whether or not they've got any serious permanent damage from a fracture through their otic capsule. So these are the messages from me, messages from the point of your exams. I'd just always keep in mind the potential complications of temporal bone fractures. These will come up in your exams because we love talking about them, because they enable us to speak about all these different themes. About hearing loss, which can be conductive if the ossicular chain is disrupted. It can be sensorineural if the otic capsule is fractured. Think about balance problems, which are permanent if the otic capsule is fractured, and temporary if your patient has BPPV or just some post-concussion syndrome. Have to think about facial nerves. Is the injury complete or partial? Is it immediate or delayed? And think about CSF leak. Think about breach of the dura, both in the short term when the patients have their acute trauma, and also in the longer term if they're having pressure-related symptoms. Might they have a perilimb fistula following their temporal bone fracture? And I think that is all I'm going to say to you, and we're going to have some questions and answers to finish up. So thank you very much for having me.